Good afternoon, and welcome to Securing the Expanded Attack Surface Created by a Remote Workforce, a Health System CIO Media Inc. production sponsored by IGEL. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of Health System CI, and I will be your moderator today. We're looking forward to your participation. You can send in your questions or comments at any time in the Q&A box, and we'll take those later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35 to 40 minutes with our main panel discussion featuring Chuck Christian, CTO at Franciscan Health, Christopher Franz, CISO and AVP of IT Security at Mount Sinai South Nassau, and Chris Feeney, Healthcare Workflow Specialist with IGEL. Well, let's jump right in. Lots of good stuff to talk about today. Chuck, let's start with you. Can you give us an overview of your organization and your role?
Sure, happy to. I'm the Vice President and CTO for Franciscan Health. We're a 12, 13 hospital system with about 350 to 375 locations, depending upon how you count them, throughout Indiana, Illinois, and southern Michigan.
Very good, Chuck. Thank you. Chris Friends. Sorry, I got to be clear.
No worries. I'm Chris Friends. I'm the AVP of IT Security for Mount Sinai South Nassau, which is a hospital system in Long Island, New York.
Very good. All right, Chris Feeney.
Greetings, everybody. I work for IGEL Technology. We are an endpoint operating system, and my role specifically has been in our partner development organization. But I came to IGEL after almost 13 years at Imprivata, spending many times in the healthcare sector, watching and seeing how those folks did their work, both in the clinical setting and the outpatient setting, but also, disclaimer, I've been a remote worker since 2005. So the balance of user convenience and security has been top of mind for me for many years to try to figure out what is that right thing. So I'm looking forward to today's conversation.
Very good. All right, Chuck, we're going to start with you. Describe some of the challenges around securing a remote workforce.
Well, let's see, how much time do we have, Anthony? So, well, actually, at Franciscan, we've had a body of folks that work remote for quite some time. Our coders have been remote for many, many years. And so we were pretty well positioned. But when COVID hit, we moved about 6,000 people to remote work in about 2.5 weeks. Fortunately, we had started working on some of the technologies that will allow that transition pretty quickly. But some of the challenges that we ran into is you have to deal with people's own home networks. And most of the services that are out there now is all wireless. Very few people have Cat 6 in their house. And so then you have a variety of equipment. And then the one thing that we were working on is standing up an expanded VPN service. We had one service which was a very small number of licenses, about 1,200, and we didn't have capacity. So we had already started testing Global Protect, which is part of our firewalls, the Palos firewalls that we use. And so we had unlimited licenses for that. And so that was a real plus. And so I've always said I'd rather be lucky than good looking, and I got my wish. Is that we were fortunate we were standing that solution up and Teams at the same time, because trying to use some of the other things that we had just wouldn't have worked. And so I think dealing with remote folks that had never worked remote before, and ensuring, because a lot of people wanted to let me just remote into my desktop, and we said no. And I think one of the biggest things for us from an infrastructure standpoint is we have a really great working relationship with our security team. And we stood up some every evening after 5:30, kind of gather everybody together. What challenges are we having today? And we really worked as a really great team in order to, address the issues that were coming at us hard and fast. And so that, for me, the challenges were, was speed, how quickly we needed to do this, and ensuring that we secured endpoints that were, even though they were our assets, they were not sitting on the first part of their network was not secured. So we have to secure the assets as well as once they securely connect back into us.
All right, very good. Lots to dig into there. Chris Friends?
I would definitely agree with what was said. And I think speed was one of the major factors, was how fast you had to make the transition to remote work, to telehealth, and to various technologies. And I think one of the things the pandemic really showed was how useful IT investment could be. Because I think one of the big disparities was how difficult it was to scale for remote work, largely depended on how much IT investment hospitals had made previously. I think hospitals that had invested heavily in IT and security were able to scale pretty securely, scale pretty rapidly. Hospitals that had less robust investments in information technologies had a much more difficult time. So for example, the hospital I worked for during the start of the pandemic, we had a fairly robust VDI deployment. We had done zero trust with the VDI deployment. And once COVID hit, we were able to securely scale pretty easily. It's just a matter of limitations of server capacity. But the infrastructure for doing remote work and for doing remote work securely was already in place prior to the pandemic. So it made it much less of a challenge for us than it was for a lot of other organizations. But I think speed was the big thing. And the thing that worries me about as a security professional was, I think for a lot of organizations, how quickly they rolled out these technologies without necessarily testing them, because at that point, the pandemic and the patient safety needs were critical. I think is going to leave hospitals vulnerable for a long time to come in a lot of ways they may not realize yet.
Interesting. Very good. Chris Feeney, your thoughts?
So at IGEL, what we saw, referencing the early part of the pandemic, was companies trying to secure the assets. Were they having them send the devices home? How could they manage them? And also, can we find devices? If not, are we going to allow the end user's home computer with who the heck knows what is on it to come in on VPN and access our network? Or are we going to provide something that we would be able to manage and control that user experience? And so that was one of the biggest shifts we saw, was an uptick in that. And then, what was interesting is the fact that many folks, were like this picture I have, we were used to going into the office, that city, those buildings behind me, essentially. Now they were trying to figure out how to work from home in a scenario where they just weren't used to it. Some of us have been doing that remote work for years. It wasn't really a shift at all, but that transition, and then of course, throw in the fact that help desk calls, I'm having trouble. Can you remote in and see what the user is experiencing, and troubleshooting and figuring out if it's just, the home Wi-Fi is an issue, or they just, something's wrong, whatever. And so those were some of the challenges of being able to have the ability to provide a good user experience. We also saw them rolling out technologies that may not have been fully tested, as Chris Friends mentioned earlier. And so I think that kind of covers the gamut. There's much more we could certainly dive into.
All right, well, let's move on. We'll definitely follow up with some of that stuff. Do you allow remote employees to use their own devices? If so, what additional measures have to be taken to secure those endpoints? Chris Friends?
We do not actually. So we have a policy against allowing personal devices on our corporate networks. We force basically users through a VDI solution. So if they want to remote in from home or do any kind of BYOD, it basically forces them to connect to a virtual desktop infrastructure first. And then the virtual desktop infrastructure can be used to access the rest of the network. It's a way of providing a layer of segmentation between the personal device and the corporate network. So it's not something that we allow.
Okay, Chuck?
Yeah, agreed. That's exactly our approach. I have a bunch of equipment at home, and they won't even let me connect my own equipment because we have to secure it. It has to be one of our images, and we have a virtual desktop infrastructure policy as well. If we have folks that are going to use and one of the things I'm trying to move to, particularly for our contractors and people that are working remote, is, they can use their own equipment, but they have to use, a virtual desktop in order to communicate with all of our assets. And we also have used some offshore consulting work, and we geofence everything. So they have to come in and bounce into a server in the U.S. before they can, get into our system.
Chris Feeney.
So IGEL specifically does not allow personal devices. Corporate provides that. We actually are beginning to roll out Windows Virtual Desktop, or excuse me, Azure Virtual Desktop. Forgot the name change there for a second. And testing that out. I personally use an IGEL device, and I just remote into office.com, or I can connect to my corporate laptop, just sort of REP to it and use it as a VDI if I wanted to. So, but it is a managed device essentially that IGEL controls. But as far as me getting my own personal device at like Best Buy, that's not allowed.
Chris Feeney, what you heard what Chris Franz and Chuck said about the way they're doing it. What are you seeing from other customers that you deal with? Are they
So,
similar?
Yeah, so very much so. It's that zero trust, is really kind of hit home. I think certainly eyes were open with the SolarWinds attack. That was huge, and to the point where the federal government mandated changes there regardless. And so it's going in that direction. And so what we also saw was and have seen certainly is you think about Teams, for example. I think the CEO of Microsoft, Satya, basically said they saw like 2 years worth of development happen in like 6 months or 3, whatever, just have rapidly, quickly that thing and being adopted. So those collaboration tools have become a must-have. Being able to do things like this and getting work done, that has become a must-have. Very similar to years ago when if you're traveling, you go to the hotel. If you didn't have Wi-Fi or high-speed internet, you were leaving the hotel. You were going to find somebody else who did, and it was just becoming a must-have. It used to be dial-up. Now it was just Wi-Fi, whatever. It's people expect it, and so rolling out those technologies. But more the really key thing is we've always been talking about the year of VDI. It just keeps going down. But we really saw an uptick in the adoption of a cloud-based solution or rapid expansion of an existing on-prem VDI solution or hybrid approach. And so IGEL has been able to help because we can get you to any of those environments, more specifically from a secure device. And so that has definitely taken off. But it has, at the end of the day, regardless of what you're connecting into, if the remote user if you don't have security around it, but the user experience is poor, they will reject the solution, and they'll either go with a shadow IT solution that you don't want happening, or they'll just try to go find some other place to work that maybe offers a better experience.
All right, very good. Next question. Chuck, we're going to start with you. IT professionals have always worked to balance security and usability. Has that gotten more difficult in today's remote work environment? Are there measures you need to institute that slow employees down? And how do you convince, if so, how do you convince them these are necessary?
Well, there's a lot to unpack in that question, Anthony. So I think there's always, it is the trick to balance security and usability, particularly when we're working in a healthcare setting, because the clinicians and the providers, they just want to do their job, and getting to the information and how they get that information, making sure that it's secure is really not something that they're aware of, but it's not something they think about. They just want to get to the information and do their job in order to do that. So that's really not an issue from a remote standpoint. But if you think about it for a moment, that every one of our locations are remote from the data center, but we control part of that because we have physical wired connectivity to them. But the remote staff, it's really not any more difficult because you've heard Chris Friends and I both mention that we're using virtual desktop environments. And so those are running on infrastructure, either in the cloud. That's our environment that we can control the security over, and we can control the GPOs and everything else that goes along with how that's configured. The same thing would go whether it's a virtual desktop that's actually running on a VM farm sitting in our data center. So it's those type of things. And the image I use on my desktop, which is actually my laptop that's sitting in my office right now in a it's hooked up to everything. It's the same one I take home. And so we secure it exactly the same way. The only difference is when I get home, I'm connecting securely with a VPN connection rather than, and then we're looking at the possibility of implementing an always-on VPN. That means as soon as I fire up my laptop, it connects to the organization on the back end. And the other thing that we've done is we've removed the possibility or the capability of allowing people to connect to their personal, like Outlook or Gmail and that kind of stuff. If I'm on the corporate network, I can't even get to it. If I'm on my laptop and it's connected to our VPN solution, I can't get to it. If I want to do it on my laptop, I have to get off of it. So there's a way that we secure it, and it's no different in my home than it is when I'm in the office. So the experience is very, very similar.
Very good, Chris Friends.
Rather than kind of reiterate what he said, I'll take it from a slightly different angle. I think the key for answering this question is to remember that at the end of the day in healthcare, cybersecurity is a key component of patient safety. One of the things is that anything that causes an interruption in availability of the system is something that can lead to adverse outcomes to a patient because it leads to delays in care. And I think the really important thing that's missing from a lot of the security equations today is that we don't consider the clinical risk when we factor risk from a cybersecurity standpoint. We often think about risk in terms of what an asset's worth, what kind of data is on the asset, how exposed is the asset, traditional cybersecurity metrics. We don't think about things in terms of the risk to patient care. And I think what's becoming increasingly important in healthcare cybersecurity is to begin to wrap the clinical context around a lot of the security decisions we make. So for an example, let's take a case of 2 CT machines. You have a CT machine in an offsite clinic that provides outpatient care and it goes down. It's an inconvenience, but it's not a huge deal to the operation of the hospital because you reschedule a few patients and that's the end result of the outage. You take that same CT machine in an emergency room setting, and now if it goes down, it's a huge problem for the hospital because you can't triage stroke patients, and the hospital may have to go on diversion because of that. And I think increasingly we need to begin to wrap the security decisions we make with this kind of clinical context. And I think that requires a partnership with clinicians. And I think that helps the clinicians gain a better appreciation for why certain security exists and makes them less resistant to efforts like this. But I also think it's important from the IT side because we need to make sure that we're protecting the systems that are most key to the operation of the hospital. And there's no way to do that without putting this kind of clinical context in scope. So I think the really important way to answer this question is to find that commonality between what IT security wants and what the physicians want, which at the end of the day is the same goal of keeping patients safe. And I think a lot of that is dependent on IT increasingly speaking the language of physicians. So for example, if I begin to talk about denial of service, the average physician doesn't care. But at the same time, they really do care about the concept of availability and having access to PACS and to the EHR and other systems you need to treat the patient because they understand the patient safety impacts of that. So I think a lot of these security measures that we need to push through, you can get a lot of buy-in from the organization as long as you can begin to speak the language of the physician and wrap the clinical context around why you're doing what you're doing and how it's going to keep the patient safe. And that kind of eliminates some of the barriers that you have traditionally seen where clinicians don't want certain types of security.
Well, and I'm going to pile on to what Chris said and offer something up from a clinical standpoint. As I mentioned earlier, that the clinical staff typically, they want to get and do their job. They don't really want to worry about how do we secure the workstations and that kind of stuff until it impacts them. And I used to have some conversations with a friend of mine who was actually my internal medicine doc about privacy. And it wasn't until he got a phone call one day from the Office of Civil Rights because someone had filed a complaint about the fact that he was having a conversation. He did some work in the rehab group. He was having a conversation with a patient in gym, and all the other patients heard the conversation. So one of the patients filed a complaint, and so after he had a conversation with the Office of Civil Rights, he became our advocate for privacy and those type of things. So when those security and privacy events occur to those individuals, it's then when they get they actually get the attention and start understanding what the true impacts of those type of things. And Chris, I do like your CT metaphor. If it's sitting out in a routine clinic, it's not a big deal. If it's in the emergency room, it is a big deal.
Great points, Chris Feeney.
Yeah, just echo a lot of that. I learned quite a bit from my my years in the healthcare space there, learning that, I mean, at the end of the day, security has to be invisible to the user. They just need to be able to walk up. If they're treating patients, you want to give them an experience that allows them to basically do what they went to med school for, or special training, whatever it was, and not really think about the fact that you've done everything you can to make sure that that device that they're on has been secured and it's not vulnerable. Some of the challenges that we have actually seen but before I go there, one of the things is as at IGEL is an endpoint operating system designed really from the ground up with security in mind. The key thing is, and what we've been working on more specifically, is providing and the ability to do as many workflow configurations as possible from that device. A lot of those workflows are driven from a VDI or a Windows-based experience or app delivery type thing. But really thinking through, what is that user going to walk up and be able to do and not have to worry about whether the machine is operational or not. And we have literally seen situations where leveraging technologies that were already in place, deployed, Windows machines getting attacked, taken down, the IGEL devices staying up and operational, or quickly bypass a device that was compromised to get up and running to either a backup operation or whatever like that. And so, but at the end of the day, it has to be usable for that user. And so that to Chris Frenzer point earlier, patient care is at stake. We have literally seen situations where customers had to send patients to essentially their competitors because they were down. They could not treat patients. They had to send them over to another facility, different health system, because they just couldn't handle it, and they were dealing with an IT security issue. So preventing that so that patients at the end of the day can be treated, whether it's in the ED or in a surgery center or outpatient clinics or triage, whatever it might be. That's really the core focus of what we're trying to help.
Very good. All right, next question. Let's start with Chris Friends on this one. How do you educate remote employees on the measures they need to take to keep the organization secure? Do you need to trust them more in a remote work environment than you did when they were working in the building? Do you worry they let their guard down at home? Now, from what Chuck is saying, it's a very similar experience because of the VDI and the VPN. It's a fairly similar experience. But your thoughts, is it in your mind similar now because of the technologies, or is it different in that they have to think differently they have to think more about security when they're at home?
In the case of our hospital, I would agree with Chuck. It's also similar. It's probably not the case every hospital, though. In terms of training, we handle training from several different perspectives. One is we do constant phishing training. So every month, everybody employee gets a phishing email. We provide training based on whether the person clicked. We do weekly security awareness messages where every week we have a scam of the week where we keep people informed of the latest threats. During Cybersecurity Awareness Month, we also have basically daily training where we provide people videos to watch and security messaging every day. We also have some gamification of that where we have little contests and stuff to encourage people to participate. For example, you might get a gift card if you spot the most phishes that month or something along those lines. We also have annual security awareness training for HIPAA compliance. So we do quite a bit in the security awareness space. Overall, I do think it is pretty impactful. But I would kind of go back to, I guess, the previous points about the clinical context. I think one of the important things is to really get the buy-in from the physicians and the other clinicians in the organization is to stress that The reason you're doing all this security and the reason security awareness is important is at the end of the day, it is a patient safety issue. And I think the more and more that gets across, the more the physicians and other clinicians are willing to participate in that because they understand the rationale for it. I think the key in security awareness is to get everybody to realize that security really is the responsibility of everyone in the organization. It's not just the responsibility of me and my staff because we have IT security in our title. It's really something that everybody has to play a role in the organization. And the more effectively everyone does, the more secure the organization is going to be.
Excellent, Chuck.
Well, and I would agree everything that Chris said. The only other thing that has come to my mind is when you're working in a hospital or in our building, which is not connected to a hospital, it's a secured environment. So you kind of know the people that are wandering around. And if I want to get up and go get some coffee, I may or may not lock my workstation because it's a secure environment. The only thing that we've made clear on, because people are working from home, is they need to have a defined space that everybody's not kind of wandering by. And if you do walk away from your workstation, lock it. And so the kids can't get on it and surf the internet. Your wife can't get on Amazon and order some stuff and inadvertently see something they shouldn't see. So I think that it's like Chris said, it goes along with the education, and I absolutely agree that security is everybody's job, just like patient safety is everybody's job. And you can't relegate it to a small group of folks in one department of the organization. We have to be aware of what we're doing. And it's like putting cars on the highway. Everybody has to be worried about everybody else's safety. You can't have one person worrying about it and everybody else driving the wrong way on a one-way street.
But Chuck, it is interesting. So there is some home specific information, mostly, as you said, around who's physically going to have access to that device. And you mentioned in the workplace, you need a badge to tap in to get into certain areas. Certain areas are more secure than others, but in the home, we have no idea who's walking around. Doesn't have to be just family members, could be children's friends. You said it has to have some sort of dedicated space, and you walk away. So that's education again, education. Yeah, very good.
And it goes along. We actually have an agreement that remote employees actually have to read, and here are the things that you agree that you will be doing in your home if you're going to work remote. And so they sign that agreement. But we don't have a method of going to their home and audit it. I'm not going to go out and knock on the door and say, it's the security police. I want to check your workspace. But we have the right to do that if we choose to.
Really?
Yeah.
Interesting.
Based upon that. And that's the same agreement that we used years ago when I was at Good Sam, because we let the coders and the transcriptionists go home, over a decade ago.
Chris Feeney, your thoughts?
So internally, IGEL has an LMS that we use, and our security team does have requirements for security training. Oftentimes, our security team will send out alerts. We've been experiencing phishing attacks or attempts or whatever. We have an internal email that if we suspect something, we can just forward it on to say, hey, I think this is. And some people may be more aware of it. I've been, in the security realm for a long time, so I'm much more attuned to that. But we do have sort of that internal education and required training. And then, of course, as I mentioned, there is some avenue of trust. I mean, majority of our workforce is remote, even before the pandemic. And so there was an avenue of trust there. We have information that you're going to see, and but I do think it's that balance, right? That trust. If I am given a user experience that works, and the security is, I'm going to use the word friendly, and not something that's abnormal. I mean, acceptable, right? So, for example, everybody's kind of used to that mobile app push experience, right? It's not intrusive. I have a phone with me. I log in, and I'm going to get prompted, and and it's not really that intrusive to access and get to my workspace essentially. um, Versus one, for example, when I was I was in Michigan and I went to a show and I was talking to police officers and I said, show me what your user experience is like. And he turned his laptop on and 15 minutes later, it was finally operational in a police car. And I'm like, are you kidding me? And he had to go through all these steps just to get to a place where he could actually work. And I said, well, come see me. Let's talk through some of this because I think there's maybe some ideas here. We can maybe streamline some of that a little bit. But all these measures were put in place and it made his job or anybody that was in that field a little bit more challenging, especially if they're dealing with a situation. And you imagine in healthcare, they're trying to solve a problem. Somebody comes in from an accident or whatever like that, and then some security thing prompts them and just breaks their train of thought. These are things that have to be thought through, and whether they're remote or even inside the hospital. But education certainly goes a long way, and the reminders, the big picture, what are this is all about. Patient safety has to be patient at the end of the day. That's what we're trying to protect.
And so, Chris, I think you've just come up with a new use case for Imprivata's tool in the police force. Tap your badge in, get it going, and tap your badge as you get out of the car. Just kidding.
They used to do that. I think they're beginning to refocus, but it was I have some family members in the law enforcement sector, so that was top of mind for me at the time. So
Very good. All right. Next question. How do you handle work-related printing at home? I've heard this is a very tricky issue. I see people start to have little spasms when you talk about printing at home. Chuck?
next question.
Yeah.
I'll give you the good Six Sigma answer. It depends. We have a policy that says you cannot print from home. But we do have some folks that their jobs require them, like risk and legal and that kind of stuff. And so there are incidences where we provide equipment for their home, and it depends upon their role. But routinely, printing at home is not allowed. But I've actually had folks tell me, well, you need to let me do it because I'm taking, what I need to print and emailing it to myself at my other laptop on my personal computer, so I'm printing it from home. So, we discourage it. There are ways around it. It's impossible to police. And so what we try to do is manage it with policy. And I actually, my office is about 40 minutes from my home. I will save stuff up when I know that I'm coming in the office, and I'll just send the print job to the big MFD that's sitting out here in the team space. It'll be collated, stapled, ready for me when I walk in the door, and I just pick it up.
Chris Friends?
We do block remote printing as well. It's something that we don't encourage. As Chuck mentioned, there's occasionally the case for an exception for certain roles, but for the most part, we do everything we can to block remote printing. Because it is a risk for the organization, and it's something that's very hard to control because you can't control somebody leaving that pile of papers on the subway or in the cab or something else, and it's all risk. And it's in the days of EHR access and people having the ability to access this stuff from home and remotely, it makes a lot less sense because there are ways you can look up the information without putting the organization at risk. So it is something that we tend to discourage and block wherever possible.
I wonder if this is sustainable. I mean, in terms of as people continue to work from home, I mean, printing it can be very important. Like you said, there's exceptions, but can you see a solution to this that will allow people to work and print from home that will take some of this away? Or is it just the nature of it becomes on a physical piece of paper, and that cannot, then we never know what happens with that?
I think it's the nature of the problem, but I think also too with technology improving and additional ways to access the information, I think there's less need than ever before to print for most roles. It's because if I'm a physician, I don't need to print out a patient's chart to read it at home to further analyze it. I can now log into my VDI desktop and open the HR software and look at that same chart. So there's not as much of an explicit need to print it as there was in the past.
I just think it's a personal preference thing. So depending on what I'm going to read, if I'm going to read anything, usually if it's longer, I'll want to print it out. And then that's the way I want to consume it. But Chuck, do you see this as an issue that's going to need more work?
Well, I think that I agree with Chris is that you right now you can't tell what's being printed out if it contains PHI or if it's a Gartner article. I'd love to print Gartner articles out and or stuff that may be a class report or something that I'm studying and I want to put notes in the page. I'm an
Right.
old guy, so
Right.
I like to do that. But the thing about it is, it's like Chris said. If I print something out, the hospital loses total control of it, because you can't just throw it in the garbage can. I don't know how many people have actual shred bins. Anthony, you may have one at your house, but I don't have a shred bin at my house. My wife has a shredder, but I'm not going to walk down and shred it. It's too easy to slip up, and so just having a general policy around you're not allowed to print removes some of the risk profile for the organization.
Chris Feeney, any thoughts?
Well, I think I would echo that. Having that base policy in general, for various reasons, our being healthcare, we have a lot of regulations and security reasons. Printing at home is a non-starter. Exceptions will be reviewed as needed, but by default, that would be certainly a recommendation based on all kinds of things. But it really comes like, where does the information reside? Can it be downloaded to the endpoint or the device being used at home, and then somehow that shadow IT kind of then approach of, now I can print it and go bypass those policies. I mean, there's lots of security tools out there that can be used to kind of control those things. We have printing partners that can provide solutions that may be able to help solve for that. I'm not an expert on all the printing options out there, but I think I would definitely echo with what Chuck and Chris have said. By default, printing at home is a non-starter. If you need it, let's have a conversation why.
All right. All right. So sometimes I'm wrong, even though I don't think I'm wrong, but occasionally I could be wrong. That's fine.
You're a legend, my friend.
I like to print, but understood. Okay, let's do this is a great segment. Ask a co-panelist. Let's find out what our panelists are curious about hearing from each other. So Chris Feeney, let's start with you. Do you have a question for one or both of your co-panelists?
I'd like to hear from both on this particular question. Sort of, you've mentioned some of the infrastructure that was either already there or being deployed at the onset of the pandemic. More specifically, your plans for adopting either a DaaS solution, public cloud hosted, or a hybrid approach, expanding VDI, that type of thing. Certainly toss a coin who wants to answer that, but just your approach and strategy around that.
Let's go Chris Friends first.
Well, we had actually been deploying VDI for a while in the hospital, so it wasn't a new initiative. It was actually an initiative to basically improve patient care, improve turnaround times. Because one of the things we noticed is a great advantage of VDI, for instance, is the Follow Me desktop. So a doctor could log in at any station in the hospital and have their EHR and other records follow them. So for a lot of other reasons, we had been deploying VDI. But when the pandemic hit, it also provided a really easy way to scale the remote access, because our remote access was basically, you establish a connection, you go to a VDI desktop, and that grants you access to the EHR and other applications. So it just became a question of scale at that point and not functionality. So it kind of goes back to my earlier point. I think hospitals that had heavily invested in technology prior to COVID did really well. And I think at scaling and dealing with the challenges, I think hospitals that had less of an IT investment had a much harder time.
Chuck Christian.
Well, I mean, I would agree. Before I joined Franciscan, they had a project of deploying VDI that didn't go very well, and so there wasn't anything active when I joined a little over 3 years ago. And so we've been running. It's kind of there's a broad swath of options out there. We can run it, the virtual environment in our own data centers. And then there's all kinds of options from the cloud. And so we've been running some proof of concepts, because some of the options have, pretty good, management platforms or management planes. Others, not so much. You have to do a bunch of stuff with scripting and those type of things. And so we've been running some proof of concepts, trying to find that sweet spot, because I absolutely agree with Chris Friends is that one of the things I want to do is provide a different experience for our customers, where they log on in the morning. It could be from their home, and then when they get to the office, to the physician's office, and then go to the hospital and make rounds, their desktop just follows them. The same thing for the nursing staff when they're going from one patient room to another. Tap your badge, and where you were in the last patient's room, your workstation is just right there with you, because it will enhance their workflows.
Mm-hmm.
And so we're actively and have budgeted in order to move a portion of our team. I don't think the entire organization workflow will benefit from a virtual desktop environment. I think that we have to be very careful about how we do that, because some of the things that we call knowledge workers and stuff, they need the power on their desk, because they're even at the best virtual machines in the cloud. There's a little lag, and some folks, even I complain about it sometimes when I'm using my virtual desktop, is that I'll type, and then there's a second, not a second, they're microseconds, but it's different than working on an actual machine. So we need to make sure about which environments that we put that in.
Very good. All right, Chuck, do you have a question for one or both of your co-panelists?
Well, I mean, actually, I think that both gentlemen, I'm very pleased and honored to be on a panel. So, Anthony, thank you for asking me. So, I guess the question I would ask is, one of the things I've found that the pandemic caused is we had to, as Chris and I both said, we had to move quickly. So what is it that you've learned during that process that you would have done differently now that we're on the other side of it, kind of, sort of?
Chris Friends.
That's definitely an interesting question. I think it was, the challenge actually wasn't so much on the remote access side. I think for us, the bigger challenge was all the internal changes had to be made, because New York was actually one of the first states hit. It was one of the hardest hit and one of the earliest hit in the hospital, and in healthcare. And one of the challenge was actually all the internal changes had to happen to the organization. So creating all the additional capacity for beds and other stuff like that. And that's what we actually found most challenging, was getting all the medical devices and all the supply chain issues. Even silly things like buying webcams and stuff turned out to be a huge issue. So for us, it was, I guess, a lot of the challenges were more on the supply side. Not that we didn't have spares, but not spares to the level required to scale up, that quickly. And that was, I guess, the importance of supply chains or something heavily illustrated for us.
Chris Feeney?
Not being in a role as our esteemed colleagues here, I would just say what we basically saw was a lot of quick fixes that some panned out, some did not. And looking back, I think as Mr. Friends has referred to, those that had already invested or had a user experience that relied on virtualization, it was a very quick shift to just to scale that up for more users, whether that was additional capacity or leveraging the cloud, for example, as an option. We did see quite a bit of that. At the time that it occurred, I was actually covering federal, was not really involved with healthcare, and I saw a shift on the federal government side to quickly adopt the cloud, whether it was through VMware, Citrix, or just Microsoft in general. So, but the other thing was endpoint devices. You mentioned earlier supply chain issues. We saw quite a bit of that. I think what we saw customers begin to realize was that we have to think of this, and they'd be looking at all those things that were destined for the dumpster. They were still usable machines, and they began to rethink, okay, these are actually workable solutions. Let's put IGEL on them, and then either make them available in the office setting or send them home for the user. And now we can actually control that because it's a common operating system, and then we can get them into whatever workspace they're trying to deliver. So it was a lot of sometimes it was stumbling, but it was other times it was just executing a plan they already had. They just needed to scale it for more capacity.
Chuck, it sounds like a big lesson that we can learn from this discussion today about everyone's experience is that you you're playing with fire if you let a large degree of technical debt build up, because you're not going to be able to handle that next thing that comes, right? Because people who did not allow for a lot of technical debt, people who were investing, were able to deal with this unseen thing, this unforeseen thing happening. So would that be a piece of advice you'd want to give out today?
Is that for me, Anthony?
Yeah.
Yeah, I mean, I absolutely agree. I mean, I think that, part of our job in IT, and this has been something, I've been doing this for a long time, and I've always, I have to think 18 to 24 months out, where does the infrastructure need to be? I was a healthcare CIO for almost 30 years. And so, trying to create the strategies about where does the infrastructure need to be before it needs to be there. It's kind of like, Wayne Gretzky. You need to skate to where the puck's going to be, not where it is. And so you have to put the infrastructure in place that's going to be necessary to handle tomorrow's crisis. And those are the basics. The table stakes. Your wireless and network, remote communications. How do you secure the network and those type of things? And so you have to invest in those. And those are interesting capital conversations when you're trying to make a several $1 million investment in your wireless infrastructure, and you have hospitals that are wanting to buy new surgical equipment and new CT scanners and things that actually generate revenue. So it's a difficult conversation to have about, it's a value proposition type of thing. So investing in that infrastructure is extremely important.
Yeah, Chris Friends, it must be an interesting conversation when you could get pushback to the effect of, but it works. And you say, okay, it works today, but it's not going to work in 18 to 24 months. Is that kind of how a conversation could go? Chris Friends?
Oh, sorry, the rest question was
It's
for me.
okay.
It definitely can go that way. I think the important thing again is that partnership with the clinicians, and I think that's what helps have that conversation. Is the more you can show that your goals are aligned and that it's all about patient care and what you want to do, I think the easier it is to have that conversation. But in a lot of times, yes, definitely capacity planning for the future is definitely critical. And I think the pandemic really illustrated that.
Well,
Sorry, Chuck,
Anthony.
I'm talking about conversations, not perhaps with the clinicians. I'm talking about with leadership that's got to approve your budget you're requesting.
Yeah, absolutely. The thing about it is that the one thing that, I think that you need to drive home is how long it takes to put some of this technology in place.
Right.
I'm wrapping up a 3-year project to change out our phone system, going from 7 different PBXs to one voice over IP solution. Took 3 years. I wrapped up a 2-year deployment of a replacement of 2 different instances of PACS into one enterprise-wide solution for PACS. The same thing goes for our wireless access points. It took me over a year to get all those replaced in each one of our facilities. And so it's a matter of, it's going to take a couple of years. We're working on, I'm working with partnership with our Administrative Director of Clinical Engineering about a system-wide standardization of cardiac monitoring. It's going to take us 2 or 3 years to get this totally in place because we have, 13 different facilities that we're going to have to change out hardware and, create the centralized stuff. So it's about, some things you can hurry, some things you just cannot. I was asked once by my CEO, not here, but at another organization, that says, well, it's a computer, Chuck. Can't you get it to do that? And I said, absolutely. I can make them do anything with enough time and money.
Chris Feeney, you want to address the idea of technical debt in relation to our discussion today from your point of view?
Certainly. I think there are definitely organizations applications, we talk about this, the long tail of Windows, right? Applications that have been designed and architected, and they continue to run, but the longer they are in place, that debt begins to get increased further and further. And then you get into a situation where maybe you are working remotely and you cannot access it for some odd reason. And the only option to make it usable is to come into the office, if that's even a feasible a thing, or now you're looking at replacing it. And so uh, letting it build up, not being maintained or updated, that those types of things, those can certainly come back to haunt you later on. I think what's interesting, I think about this, 20 years ago plus, we experienced as a nation something that woke us up to, oh my gosh, and then you started saying, if you see something, say something, right? We began to accept a different user experience walking into the airport and going through a little bit more increased scan. We've all now experienced globally this onset of that forced people to work from home, and people began to realize that I wasn't used to that, but it actually made me more productive. I enjoyed it, my lifestyle, I mean, various things, and it's totally doable. And I think it is, I hope it's given folks like Chuck and Chris the opportunity to say, here's the art of what's possible. We can continue to maintain, we can continue to do that, which means that technical debt conversation hopefully will become less and less, because they realize that, okay, we can shift and we can move and we can advance further into, or shift from a CapEx model to an OpEx model, and make it more financially acceptable to implement some of these newer solutions that will help us to continue to maintain and have a great, patient experience at the end of the day.
And
All right.
Anthony,
Yes, sir. Go ahead. Go
just
ahead.
one more point. I
Please.
think, having worked at several different organizations, is that the culture of the organization and how they view IT. Some organizations view IT as a cost that needs to be maintained, rather than something you need to make strategic investments in. And I think that that's a value statement that every person in IT used to need, that needs to have. I mean, Chris Friends, I mean, I'm sure that he would agree that it wasn't until you started seeing organizations, particularly in healthcare, started getting hit with ransomware and all the other security related instances, and the millions of dollars this was costing the organizations to clean up and respond to, that funding for security actually got increased. And so I remember back in Y2K, we spent some money to mitigate some risk, and then on the day after the January 1 of the year 2000, we had a steering committee meeting, and the CEO says, "Okay, Chuck, what happened last night?" I said, "Absolutely nothing." And he said, "Well, why did we spend that money?" I said, "Because we got the outcome that we anticipated. Nothing happened."
That's what you wanted. Right.
Yeah, exactly.
Chris Friends, did you want to mention anything there?
My parting advice, and it's not directly related to the panel, but just with security, you don't ever assume you're secure. I'm a really big advocate for security testing. I think it's a mistake a lot of organizations make, is they deploy some controls and they assume they work. I would encourage organizations to actually test their security more often, try to continually validate that their security is actually working. Because when you put a lot of security controls to the test, you'll be surprised how often they fail. And I think organizations need to be a little more proactive about identifying that, so that way they're aware of those shortcomings and can remediate them before an attacker points them out for them.
I think that's a great point, and I think we could do a whole webinar on that, and I think maybe we will. So we'll look at that. Chris Feeney, final thought.
Actually, I just listening to Mr. Friends talk there. I was kind of echoing that same idea. Just you can never let your guard down from a security perspective. Put your solutions out there, but maintain that vigilance, and try to find the right balance with that user experience. Right. I go back to making security invisible, if at all possible. Users just sort of accept this is the way it is, and it's easy to use, not so intrusive, but at the same time, I'm not giving up the kingdom by opening it up too much, if you know what I mean. So that would be my final parting words.
Chuck, did I get your final parting thought? You always usually have one more. Give me one more. And no, let me give you a little context here. Let's go back to the theme today. Just something regarding the remote workers. We talked a lot about VDI, things like that. Anything you want to just a parting thought to your colleagues who are working on this issue and want to make sure their remote workers are secure?
Well, I mean, I think the point is, Anthony, is it doesn't make any difference what environment that the people are working in, whether it's in the office, in a physician practice, or in a hospital, or at home. We need to be aware of the fact that security is extremely important. And, you know, every time that we think that we have a system tightened up and idiot-proof, somebody takes up the challenge. And so I absolutely agree with Chris Friends about, you know, we need to make sure that we test it, never assume that it is 100%. You know, we take a very layered approach, and now I'm trying to turn the network and the other pieces of technology into security layers as well. So never, ever, you know, always be looking over your shoulder, because just, you know, I'm reminded of a friend of mine who was a deputy sheriff when I lived in Florida, and I had just put a new front door in and had all the fancy latches and a 3-inch deadbolt, and he just laughed. And I said, why? He said, you think that's going to keep them out? I said, well, I hope so. And he said, and then he showed me a picture of a house that had been burgled the night before, same kind of door, and it was in a V, because the people went through the door so hard that it actually bent the door. He said, if they want in, they're going to get in. And I said, well, I just want them slow them down long enough for me to get my home defenses in place.
The home defenses.
It's like my dog. So,
very good.
Yeah.
All right. Well, that's a perfect ending. Regarding continuing education, you could use the final slide in this deck for your CEU needs. You'll get an email when the on-demand recording of today's event is ready for viewing. If you want to sponsor an event with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming panels. With that, I want to thank our panel. Great discussion today. Chuck Christian, Chris Friends, and Chris Feeney. I want to thank IGEL for sponsoring and making the event possible. I want to thank you for attending. And with that, everybody have a wonderful day. Thank you.